Hello students! Today we'll be talking about anti-infectives, and I'm pretty sure that most of you have had some experience in having an anti-infective antibiotic at some point in your life. So, it has only been about 150 years since we realized that infections were actually caused by other organisms that were residing within us, or the host. Dental infections can be separated into several categories. They include caries, periodontal disease, localized dental infection, and systemic dental infection. Now, in this picture above of this precious child, look at this swelling. This is terrible. We can see how much swelling it's into his eye, it's on the side of his cheek. This amount of swelling present, I would assume that he also has some systemic symptoms such as fever and malaise, and this child would require some amount of antibiotic therapy. So now we're going to be talking about a lot of different definitions. So many definitions, but we've got to get through it. So anti-infectives are basically agents that work against infections caused by a variety of organisms. Antibacterials are agents that work against bacteria, and antibiotics are agents, chemical substances that are actually produced by microorganisms, and they work against other organisms. So what's the difference here, right? Antibacterials and anti-infectives may be developed synthetically in a lab, whereas antibiotics are made by living organisms. And also, anti-infectives is sort of a broad term, and it can encompass destroying bacteria, protozoa, helminths, which are worms, viruses. But many times we'll see that these terms are used interchangeably. And probably the one that you're most familiar with is an antibiotic. An antimicrobial is an agent that works to destroy or suppress the growth or multiplication of microorganisms. Again, another broad term. An antifungal is an agent that works against fungus. An antiviral is an agent that works against viruses. And we could go on. An antiprotozoa agent works against protozoa. An antihelminth works against worms. So another definition, bactericidal and bacteriostatic. So and I'm going to use the word antibiotics a lot here because I end up deferring to that term. So some antibiotics are bactericidal. They kill bacteria, and this effect of killing the bacteria is irreversible. If the bacteria are removed from the drug, they don't live. Now, there are other drugs that are bacteriostatic, and they basically suppress the multiplication of the bacteria. And these effects are reversible. If you remove the bacteria from the drug, they'll again begin to divide and multiply. So, blood serum level, the amount of drug in the blood or the serum. And certain blood serum levels are required for a drug to be effective. And dosage regimens are developed to maintain a certain blood level, right? Because the dose given must produce a certain drug level to be effective against an infection. If you have strep throat and you take your penicillin once every other day, you're not going to build up to the certain blood serum level you need to destroy the bacteria that are causing your sore throat. The other thing is the MIC, the minimum inhibitory concentration, and this is the least amount of drug necessary to impact the microbes. Because we want to work on that dosage, right? We want to be able to get the infection under control, but not give you so much drug that you end up with a lot of side effects because you have such a high dosage. So in this image here, we could see this is something showing us the MIC on the top line of a susceptible organism. And it looks like it's about 8. Doesn't really, let's see, 8 micrograms per milliliter of antibiotic. That's the amount that's going to work to get this infection under control. And we can see in the vials below, this is a resistant organism. This drug will not work for this organism. So resistance, right? And we're hearing about this all the time. It's on the news. Every time we turn around, there's some new infection coming that is becoming resistant to the antibiotics that we have available. So resistance is essentially the ability of a microbe to not be affected by a drug. And this could occur naturally because of properties within the bacteria cell wall. A certain drug may not work for a certain bacteria, and it never did, and it never will. What we're talking about, and especially what's in the news a lot, is acquired resistance. And this is when an organism that once was sensitive to a certain antimicrobial or antibiotic develops resistance, and that drug doesn't work anymore. And now we've got to pull out the big guns to get this infection under control. So how does an organism acquire this resistance? Well, it can happen in a lot of ways. The organism itself can spontaneously mutate, and then all future generations will be resistant to the drug. Another way for resistance to happen, now bottom line, I talk about this a lot. Bottom line is our bodies, right, ourselves, we want to live. And you know what? These bacteria want to live too, right? So actually, some organisms can transfer their DNA into a non-resistant organism. So a resistant organism transfers its DNA into a non-resistant organism, and then that non-resistant organism becomes resistant without ever being exposed to the antibiotic. And this is another thing that is happening, or did happen more frequently years ago, is the amount of unnecessary antibiotic prescriptions. All right, now look at more than 50 million unnecessary antibiotic prescriptions are written each year for patients outside of hospitals. And this is according to the CDC. Some things like ear infections, that's 30%. Common cold, 100%. If you're taking antibiotics for the common cold, it's not going to work. All right, you might get some side effects, you might develop some resistant bacteria, and then when you actually need this antibiotic, the bacteria have become resistant to it. So there's too many times that we're getting antibiotics and they're not working anymore for us. So spectrum, how many species, how many organisms are affected by an antimicrobial agent? So we could have a narrow spectrum, so only a select number of species are affected, or we could have a broad spectrum, many species affected. And so when you look at this, do you really think, oh, I want a broad one? Let's beat these organisms down. Don't forget, okay? We have good bugs. We have good bugs in us that we keep, and they help to, control and keep other organisms within our body from growing out of control. So a narrow spectrum drug specifically designed to treat the organism that's causing your infection may actually be better than a broad spectrum drug, which is going to kill a lot of your good bugs off too. So we can see here, we have some drugs, the drugs that work on the mycobacteria, which is TB. Some of those are very narrow spectrum. Look at how broad tetracycline is. Look at how broad that is. I bet that's going to be killing off some good bugs too. I bet we're going to end up with some diarrhea if we're taking tetracycline for a long time. It's disrupting our intestinal flora. So combining anti-infectives. Sometimes it's a good idea, sometimes it's not. It depends on the drugs. All right, so synergism. Combination produces more than an additive effect. So one drug plus another drug equals more than if either drug was given alone. Bactericidal combinations are generally synergistic, right? You combine two bactericidal drugs and they usually have a synergistic effect. Now, this might be a good thing. We've talked about synergism as a bad thing in the past, but this might be a good thing depending on the infection that you have. And maybe some drugs aren't working, so we need a synergistic effect. Bacteriostatic combinations are merely additive. 1 + 1 = 2. So that's good. Synergism can be good when we're combining, or additive effects can be good when we're combining anti-infectives. But we can run into a problem. There is antagonism occurs. And antagonism means that the combination produces less of an effect than either agent alone. And what you don't want to do is combine a bactericidal agent and a bacteriostatic agent, because the effect is usually poorer than if either are used alone. And the reason is this. You combine a static and a cidal, bacteriostatic, bactericidal together. What happens is bactericidal drugs work during specific times when an organism is dividing and multiplying through their division and when they're growing through their growth process. The static drug will prevent the organism from getting to that stage of division and thus rendering the bactericidal drug ineffective. Infection. The factors that determine the likelihood that a microorganism will cause an infection. The disease-producing power of the microorganism. Its virulence. The number of organisms present, how many were introduced to or within our body, and the resistance of the host. And we all know our resistance can go down when we're under stress, anxiety, lack of sleep. So take care of yourself, be good to yourself, keep your resistance up, especially as we're all locked into small rooms together with no windows. We all know when you get back to school, that's when illness happens, when we're all crowded together in locked up little rooms. So infection, we have a term opportunistic infection and also a super or supra-infection. A lot of times these two terms are also used interchangeably. So an opportunistic infection is an infection by a microorganism that normally doesn't cause disease, but becomes pathogenic when the immune system is impaired. And a superinfection is an infection followed by a previous infection caused by microorganisms that are different from the original infection. And let's look at bacteria. Let's go back to microbiology. We have gram-positive or gram-negative bacteria. We find gram-positive infections, bacteria infections in wounds and throats. Gram-negative, our guts, our intestines. That's where we find gram-negative infections. Shape of bacteria, you could also classify them by their shape. Are they round? Are they a spiral, a spirochete? And also with their ability to use oxygen. Are they an aerobe, an anaerobe? Remember all those terms, facultative, anaerobe. So these are just some images showing how different bacteria grow in the test tube. And then our gram-positive bacteria stain purple, and our gram-negative bacteria stain pink. So in an ideal world, right, you're going to go in, you're going to have your infection, whatever it is, let's say it's strep throat. And they're going to stick that little stick down your throat, right? They're going to culture it. And now they do a rapid strep test so they could tell you, right, when you're right in the office, okay, you have strep throat, although it's not 100% reliable, right? Because they get some false positives and some false negatives. So culturing involves growing the bacteria. So probably those false negatives, false positives are caused because they don't allow the bacteria to grow for a certain amount of time. And then the next step, right? The next step should be a sensitivity test. And that would be exposing the organism to test antibiotics to determine whether the organism is sensitive or resistant, right? Because has anyone had an infection and they've given you an antibiotic and the antibiotic hasn't worked? If you've had a culture in a sensitivity test, you could really align the drug to the microorganism causing the infection. But in the real world, right, when you go to the doctor and your throat is killing you and you think you have strep throat, do you want to wait the 48 hours to get your antibiotic? Do you want to go to a second doctor's appointment to pick up the prescription? You want it, right away. So, and that's the majority of people. They want their antibiotic right away to get on the road to recovery. So unfortunately, a lot of these sensitivity tests and things like that don't happen. So how do anti-infectives work? They can work a lot of different ways. Penicillin and cephalosporin inhibit cell wall synthesis, right? So here's the other thing. Think about this. Anti-infectives aren't working on our receptors. They're not working on us. They work on the bacteria that are making us sick, or the organism that is making us sick. So inhibiting cell wall synthesis is good because we don't have a cell wall. So the cell wall of the bacteria, right, you disrupt that synthesis and all of its guts spill out. So it's good. It's bactericidal. Some other drugs disrupt protein synthesis of the bacteria, so they can't make the necessary proteins to form their cell wall. The other way a drug can work is to inhibit folic acid synthesis, which is another necessary component that some microorganisms need to reproduce. And they could also inhibit the microorganisms' RNA and DNA synthesis. So we look at this and we see this little diagram showing us this microorganism and where all the different drugs work. And things like, protein synthesis, I don't need you to know it works at the 50S subunit or the 30S subunit. I would like you to know that penicillin, cephalosporins work on the cell wall, and that other drugs such as erythromycin, clindamycin, disrupt protein synthesis. Sulfa drugs inhibit folic acid synthesis. And DNA, RNA, yes, some of those drugs, ciprofloxacin, I'd like you to know that one as well. So when do we actually need antimicrobial agents? Considerable controversy still exists regarding the need for antimicrobial agents in various situations. And the two categories are prophylactic and therapeutic. Prophylactic, preventing, preventing an infection, and therapeutic is to help cure someone that may have an infection. So, therapeutic indications. No simple rule has been developed to determine whether an antimicrobial therapy is needed in dentistry. And in fact, many infections don't require it. In most patients, if their immune system is functional and drainage can be obtained, they do not need antibiotics to manage their dental infection. Prophylactically, in the dental office, we still prescribe antibiotics if someone has had a prosthetic heart valve, an unrepaired congenital heart defect, a history of endocarditis, and the American Academy of Orthopedic Surgeons has new guidelines for joint replacement. So these new guidelines, and I've given you a little link here because now we know patients in the past that had joint replacements stopped taking their antibiotics prior to dental treatment, there was a shift, and then it was determined, yes, these patients need antibiotics prior to having dental prophylaxis. Now the tide again is starting to shift. And on this link, I'd like you to read this. This new guideline, this PDF document, was created by the AAOS and actually the ADA. And we're going to look at it a little bit more closely in class. It's 3 pages long. In the 3 pages of guidelines, the only way I can describe it to you is prescribe them if you want, don't prescribe them if you don't want. But there's no rule. There's no you must prescribe if the patient has had 1, 2, 3. It doesn't say that. It really doesn't say much. So we're going to take a look at it in class, and I'm excited to hear what you think about this new guidelines. And this you must know. You must know the different drugs that are recommended for antibiotic prophylaxis prior to a dental prophylaxis. So amoxicillin, 2 grams by mouth, 1 hour prior. If you're allergic to penicillin and ampicillin, ampicillin, the cillins have cross-allergenicity, meaning if you're allergic to one of the cillins, you're allergic to all of them. And you can take oral medication. They recommend clindamycin, azithromycin, clarithromycin, or cephalexin. Now, the little cross down below indicates cephalexin is a cephalosporin. Individuals that are allergic to penicillin or ampicillin shouldn't take cephalosporins. There's a 10% cross-allergenicity between penicillin. If you're allergic to penicillin, 10% of the time you're going to be allergic to a cephalosporin, including cephalexin. So one of the top 3, clindamycin, azithromycin, or clarithromycin, may be a better choice for someone that is allergic to penicillin. Patients, you can still see patients taking cephalexin if they're not allergic to penicillin. I just find that a little surprising that cephalexin is in there because of that 10%, which isn't a lot, but there is a 10% cross-allergenicity. The other thing with cephalexin compared to something like penicillin is cephalexin is super expensive compared to penicillin. Now let's look at our general adverse reactions. We can get some GI distress from these drugs. They're killing off some of our good bugs, our good flora in our intestine. Superinfections, susceptible bacteria will be killed, and the few that are resistant can grow and multiply. Allergy, and the 2 drug classes that we see that create the most allergenicity are penicillins and cephalosporins. And many drugs, antibiotics, anti-infectives, can be used during pregnancy. 2 that are contraindicated include metronidazole, which is Flagyl, which under certain circumstances may still be prescribed, but in general it's a no, and tetracycline is a definite no. So general drug interactions, we have oral contraceptives and antibiotics. And so a lot of people know about this one. And this can happen because actually 2 ways. They think antibiotics and oral contraceptives interact and cause oral contraceptives to not be as effective. So birth control pills contain estrogen, and some antibiotics cause the enzymes in our liver to increase the breakdown of estrogens, and thereby they decrease the level of estrogens in the body and the effectiveness of the pill. The other way that antibiotics can interfere with the effectiveness of oral contraceptives is by reducing the amount of estrogens that are recirculating within the body. The estrogens in birth control pills are broken down by a conversion in the liver to other chemicals. And then these chemicals are secreted into our intestines. The bacteria in our intestines are able to convert these chemicals back into active estrogen, which is then resorbed into the body. So theoretically, antibiotics kill the bacteria that convert the inactive chemicals to active estrogen, and therefore may interfere with the effectiveness of the birth control pill. Now, antibiotics and oral anticoagulants can also interact. So erythromycin inhibits the enzymes that metabolize warfarin, also known as Coumadin, and this results in more anticoagulants in the systemic circulation. Also, antibiotics in general may wipe out the bacteria that produce vitamin K within our body, and vitamin K is a necessary component in our clotting system. And with the anticoagulants working to reduce clotting and a decrease in our vitamin K, an increase in bleeding may result. And then combining antibiotics, that antagonistic effect that we see when we combine a bacteriostatic agent with a bactericidal agent.